ideal thing to do at this point would have been to change treatment, but he was adamant that he did not want to go back to chemotherapy. He did not want any further chemotherapy, and I could not get him on the special access program for the mobocertinib at this point. So after a lengthy discussion, we decided to use full dose amivantamab and try it at that point. And interestingly enough, PET-CT in February 2024 showed areas of response and areas of stable disease, which was very fascinating for us, telling us that dosing does matter. And an MRI brain in February 2024 showed a partial response. This man never had any radiation therapy to the brain. So you can see that, again, this slide deck was prepared in February, and it had a 12-month PFS at that point, and is ongoing. He actually had clear-cut progression of disease in June 2024, at which point he stopped treatment and decided for best supportive care. And right now he's still alive, but on best supportive care. So I would say his PFS is approximately 16 months. Again, better than what you saw in Chrysalis and better than what you saw in Papillon. So thank you very much.
Thank you, Dr. Shahina. That was excellent cases and sharing your experience as well. And I would like to invite our panel for discussion of the cases. We had a great cases with Dr. Samah. She shared with us 4 cases, and Dr. Ibrahim kindly shared his case as well. And Dr. Shahina, we do have 3 cases with her. So the first question to Dr. Samah, that one of your patients, of course, the main issue that it's difficult cases, because I think the main issue that for them is the resistance for the EGFR. And we know that even for all EGFR cases, we will have the resistance down the road. But the short resistance and the patient became refractory, this is a little bit unusual. And I think you explain it that those patients with co-mutation and the PRAF as well. So the question coming to Samah, do you think those patients from the start, you may go for combination, or you may go for amivantamab plus lazertinib, are those patients not a usual cases, or what do you think? And I wanted to share the question as well with Christian. Okay, go ahead, Samah.
Thank you so much. So I think the first question is for the BRAF cases is actually if it's a V600E or not, because we need to go with the target. I had these cases actually before the era of the combination of lazertinib and amivantamab. If I have these cases today, I think I would go with the combination, because for these few cases at presentation they were very sick. So, and it was a challenge which to pick first, because I have almost very little data to tell me if they are sensitive. Most likely, we believe that majority of them, they are insensitive to EGFR. But if I have the combination, I will go for it, because they are really sick, and giving the combination, I think, is their best treatment choice.
And I think one of your cases as well, there was C797, as I remember. And those cases as well, they are very difficult to be treated. And I think the combination, as you pointed out, amivantamab plus chemotherapy, I think this is the group of patients we need to, because so far we don't have a specific treatment to this type of mutation. So what do you think?
True, but to keep in mind that actually these trials were designed for the common mutation, so it was not designed for the uncommon mutation. What I would think is reasonable, to be honest, is to try to see if we have in the literature similar data and how they were actually treated. If I have no data, then the combination I think is actually reasonable. For the C797S, I requested amivantamab for her. Hopefully I can get it soon, and then we'll add it with the chemotherapy. The other thing is also, in the ideal world, if I have an access to clinical trials, I don't, but again, she would be a perfect candidate for clinical trial as well.
I agree with you, Samah. I think we are now, even that they start for the phase 2 for the 4th generation, and there is some of the medications, they will coming and it will be launched next year, and even for the cases like the combination, and even for the Mariposa patient when they are progressing. I think our guest speaker as well, Bazero, Antonio, he also will present some of this element. So Christian, what do you think that Dr. Samah, when she presented her cases, we went for the conventional therapy. So if you do have, now we do have some data, especially the last year, it was a glowing year regarding exon 20 and also for the patient who is progressing. So if we will treat those patients now with the co-mutation and those patients shortly progressed, what you will treat them for now?
First of all, these were really excellent presentations, very insightful and very helpful. And what's really interesting in terms of understanding that we are all cooperating on an international level, there are certain kind of patterns of disease burden these patients obviously share. So I do believe what I like about the newer drug options like the bispecific antibodies is that they do have a high penetration for the blood-brain barrier. So you don't have to use whole brain or SBRT for these patients in most cases. And even in heavily pretreated patients, amivantamab sometimes does have a very nice effect. In terms of understanding, you addressed that, Mervat, was if we start with that combination therapy for first line, what comes up next? And shown later on in my talk is TKI treatment seems to be definitely more toxic than what we have at the standard of care chemo-I, or chemo-amivantamab. So that's what is tricky for me. We used up to now amivantamab in later lines, but using that in first line, what is left in our for these cases? I think this is difficult. And exon 20, as you have shown here with these wonderful presentations, they are really patients that have a high active and aggressive tumor burden. They come back soon after you treat them with standard of care. So, if we use amivantamab, we maybe have a good shot, but in terms of sequencing, we should look into that kind of data set, having started with chemo or chemo-IO, and then later on amivantamab, if they do fare poorly. I don't really know this.
Yeah, we do have one of the questions from Dr. Muhammad Hassan from Egypt. He's asking about this co-mutation and do we really need to treat them like others? And I think he was referring to that Dr. Samashi presented the EGFR plus PRF and the other patient was the EGFR plus ROS1, as I recall. So this is very challenging, which target we have to go. And what you do in your clinic, Chris, if you do have the similarity?
With the co-mutations, I loved your case with the ROS1 fusion because we had recently the patient, and it really makes a difference what kind of ROS1 fusion you probably have. There are 20 or more, and some of them do not respond to TKI treatment at all. So we have to be clever about that too. And sometimes I do believe we now just started a patient who failed on ROS1 again on crizotinib plus chemo, like FLAURA2 in a way. So that might be really interesting to see what kind of co-mutation. And the other story, and that's a question I would like to go back to Dr. Shahina, is the VAF, the allele frequency of 0.4%, or in general, the very low frequency. Is this still a tribal mutation? Do we consider this as a tribal mutation? In terms of really, is that just like making the disease a bad disease? I don't really know. This is just different from the standard common EGFR mutations. We pick up very low threshold signals for these patients. So this is a question I would like to discuss with you too. Do you make something out of this for the reason that you picked up a signal, or do you make something out of it because the signal can be addressed by a targeted therapeutic option?
So thank you. Go ahead.
No, please go ahead, Dr.
No, I love the question that you've posed because I actually asked that question. And if you see the case of that patient with the low PFAF and the exon 20, it was 0.4%. But by the time I started amivantamab, it had gone up to 4%. So there was an increase in the VAF. I think even if it had been 0.2%, and if I had the papillon data right now, I would have put him on that on papillon and given him amivantamab and chemotherapy, because this is the driver. And I've actually asked this question several times, and I got on the molecular tumor board at the Marsden and I asked this question: does a low VAF preclude you from considering this to be the driver for this particular patient? And there was a unanimous discussion there saying that it doesn't preclude you. But if there was like a whole bunch of other stuff, maybe, but if you see that it was just that 20 insertion that this patient had, and there was nothing else that was there. I think this is akin to what we're learning now also in breast cancer, where we're doing all these liquid biopsies and molecular profiling, especially in our HR positive breast cancer patients, and we're picking up PIK3CA mutations and PTEN mutations for which we have a target. And even if it's a low VAF, it's just telling me that maybe the capture rate wasn't very high. The tumor, the patient wasn't shedding that much, and that's probably why the VAF was very low at that point in time. But if that's the only thing that's there, for me, that is the driver. At least that's the way I see it.
Mhm.
Yeah,
I
Nafisa, go
have
ahead.
comments and questions at this time. It's for all of you guys. Do you think this is a time to have more flexible trials to start to think loudly about combination of chemo, targeted therapy, targeted immunotherapy? Because we are dealing with these cases as rare cases, but they are not going to be rare anymore. If we expand our gene testing and expand the profile to 300, that will not be rare. We'll be seeing at least 4 or 5 patients per month, or maybe more than that. So I think we need to have more flexible trials, encouraging and recruiting patients with co-mutation. And I think we should be brave with the support definitely of the trials in using the combination, because very soon this will be the reality actually.
So if I could comment on that, I think you've hit the nail on the head here, and I think that's completely correct. I'm on one of the molecular tumor boards in India, actually, for lung consortium, and it's insane. Because they do liquid biopsies and tissue profiling for a large volume of patients, and they have such a high pickup rate of co-mutations that we need to start actually thinking about the fact that, which is the target, which is the pathway that we're going to target. Are we going to target both pathways, which is I think the area where we're headed. That's the pathway, that's the path that we're going to be headed in terms of targeting both pathways. It's just that I think the data is lagging behind, and we're profiling so much more that we're getting into this conundrum of the fact that we have a lot more molecular information without the data to tell us how to treat these patients. And you're never going to have a clinical trial. And I don't know if Professor Christian, you're going to agree with me or not. We're never going to have the clinical trial for every N of 1 case. And I think that's where the molecular tumor boards come into play, where we all get together and say, this is the way we think we need to treat. We have to extrapolate data and obviously have a very frank and fair conversation with our patients at the end of the day.
So if I can ask another question or just discuss that with you, it's just like when Flora 2 came out, everybody was thinking about this is a step back, combination chemo plus TKI, third generation TKI, and said, well, does it make sense for our patients? In the context what we are discussing now, I think personally it does make sense. And Sonia Logus now has a clinical trial here in Germany called FLAURARE for the rare exon 18 and 20 and 21 mutations, combining osimertinib plus carboplatin and pemetrexed. But it's exactly what you were saying. You probably have you have the classical driver mutations, and you have co-drivers or passengers in the seat you might hit with the other options these days. And I think this is exactly what we have to look for. MET amplification is definitely something we have to look for, or other escape pathways. So, and we will not have any kind of clinical trials, even with large data sets, for all these questions we would like to address with these rare mutations.
So if I could play devil's advocate, can I have 1 minute, Dr. Mehmet?
Yeah, absolutely.
Such an interesting conversation. So if I can play devil's advocate here, I completely agree with you that, the 2024 explosion of data, you've got Flora, you've got Mariposa, and let's just say we have everything available, because if you look at the cost of lazartinib, none of you are going to use lazartinib in combination of amivantamab. But I think it's a very cool combination. When I saw the translational data of Mariposa at ESMO, what it told me was that, and you didn't see that with the Flora study. So when I saw the translational data, I said, okay, so you're giving the combination of lazartinib and amivantamab, and those resistant mutations are definitely, we're delaying those emergence of resistant mutation, and they're not as complex, those pathways, post-progression. So should we not be actually thinking of using this more of a combination in select group of patients, of course, not for everyone, because I still think there's a role for single agent osimertinib in patients. But do we really, I mean, is there one regimen that you would think is more superior than the other? I mean, I feel like the combination of two agents that are targeting different pathways seems to me like amivantamab is preventing those resistant mutations from actually happening at a much later date.
Yeah, I guess what you're saying, Shahina, is super important. And I think with the Mariposa study and the subgroup analysis, when they look at the resistant group, they found that the patient with a combination, it was in favor for the patient who received combination comparable to the patient with osimertinib. And just give us a hint that this means that this combination, it can be like a golden standard, like a better regarding the resistance, and they looked at the MET amplification and P53, and I'm not sure about the HER2 as well, but this was the one that there was a significant difference between the patient with osimertinib to the comparable. And I think this element is super important, that because we know that all the patient with EGFR mutation, we know down the road this patient, they will develop resistance. So delaying this point, I think it's important. But our issue that we're still not familiar with the medication. Still, amivantamab has its toxicity as well, and also we have to look at the cost. But putting aside, we can see that regarding the resistance, we can see there is. If I recall, it was about 17% comparable to 2.3 or something regarding the MET amplification. And what do you think, Chris, on this part?
In terms of the resistant patterns,
yes,
I personally believe, this is something where we have to look for it. What's interesting is that you have presented cases here which have a long-standing effect on amivantamab, obviously more than what we've seen in the clinical studies. But there are patients who fail that amivantamab does really help. So obviously there's two different kind of groups of patients in terms of understanding what is the co-mutation for these patients.
yeah.
I think this is one issue. The other issue we didn't address, obviously, there are amivantamab non-working patients. And the other is the issue of toxicity profile. And we have been participating in these clinical trials, and we also used the sub-Q versus the IV combination. There is definitely a learning curve for that drug. It does work. But it should just like being trained for certain kind of outpatient centers. It's just like to be capable of understanding what's going on. Usually within the 2 to 4 first cycles, after that everything is fine. But thromboembolism is a critical issue, and skin problems definitely are also problematic in this patient. At least the patient we do see, right?
I think. Yeah, I think Dr. Ibrahim as well, he presented in his case, he described fantastic the infusion reaction and how he deal with the patients. And also it was a learning point that those patients, they maybe have a severe toxicity, and then when they recover, they still have a response, which is really good. And I think you are not considering the skipper trial, which is they put the schedule for this patient with initial steroids, and the day before, I think they took the same manner like on the paclitaxel and docetaxel the day before. So they are giving, I think this is important to be learning as well, that the skipper trial is giving to the patients dexamethasone tablet before the day before twice, and then before infusion, and there was a significant decrease in the infusion reaction. And this is why when we are having the medications, we are learning how to deal with it and also to decrease. So, Dr. Ibrahim, did you see that because what do you think regarding your case, and thanks for sharing. So I think now they are putting that for all the patient with Amventamab, they are giving them steroids upfront the day before and also during the medication at the time, plus antihistaminic, and also and this has decreased the infusion reaction as well. But the issue that your patient also, she has pancytopenia and also has mucositis. This is very challenging.
Yes, she passed through a lot of side effects. And in fact, after the infusion reaction, she was refusing to continue treatment. We convinced her, we monitored her, and she passed the cycle very well. However, when later she developed more toxicity as I outlined, that mucositis, skin rash, and fatigue. Really, she was refusing to continue further treatment. We convinced her toxicity usually happens in the first cycle. We're going to give you the second cycle with a good pre-medication and in-house monitoring. She accepted and she did very well. And so far, she continued the full course of treatment without no further toxicities. And I think it's very important to keep an eye for side effects and how to manage it properly.
Perfect.
So
I do have
Dr.
a
Ibrahim,
director, if you say yes.
for Dr. Ibrahim, with the second cycle, subsequent cycle, what did you do? Did you just top her up with the steroids, or you also adjust the dose, like we went for dose reduction, like 20%, 30%? What did you do?
Yeah, the dose reduction to 700 plus the standard pre-medication, the steroid antihistamine medication, and she continued the treatment as outpatient, and after that she's fine.
So there was resolution with the dose reduction, resolution
Yes.
of all symptoms. Okay.
Yes, exactly.
That's great. Okay.
And you did have any manifestations on the subsequent treatment, or it was only on the first 2 shots for the patients?
The reaction on day 1 of week 1, day 2 of week 1, we did it in prolonged duration, no issues. Infusion reaction, related reaction, after recovery from her other side effects, did not happen again. Actually, as I said last week, overall, she has almost no symptoms. She's receiving treatment and going back home. She's perfectly well.
Perfect. Thank you for sharing. That was very interesting. We do have a question from Dr. Mohammed Sahibani from Saudi Arabia. I think he's asking about the case of Dr. Shahina, that I think he's asking about the role of immune therapy on such cases. I think he may referring to the case. Dr. Shahina is still with us?
Yes, I'm here.
Okay, my dear. So I think he was referring to that you started with your case initial was IO plus chemotherapy. And so most of the time we are thinking that the patient with the driver mutation, they may not have the benefit from IO. So he's asking, Dr. Muhammad, he's asking about the role of IO therapy in EGFR exon 20 patients. Do you recommend for them IO therapy?
So he's completely right. I do not advocate for using immunotherapy in these patients. This patient had actually started his first cycle outside and then came to see me. So I just continued it. But I don't think it's also wrong to do so, because if you come to think about it, most of the trials excluded patients with EGFR and ALK, but the common one, not specifically exon 20. So you're going to have some patients in those trials that received IO therapy that have the exon 20, and the guidelines don't exclude you from using immunotherapy. But having said that, me personally, if someone were to ask my opinion, I would prefer not to use immunotherapy, because I honestly think that there is no benefit in these patients. You're probably just adding toxicity with no benefit. And I think we've had a lot of anecdotal evidence that have suggested that anyone who's got any form of a driver, immunotherapy is not going to be as effective. But in this particular case, this patient had already started, and that is the reason why we just, continue. This happens when patients tend to shop around a lot.
Perfect. Last question from Dr. Hind from Morocco. She's asking, in case of resistance and progression, are we going for the quadri-therapy? So the question for the panel and for Chris as well. Okay, Samah, go ahead.
Sure.
Yeah.
So for the quadruple, it's an option. Personally, I don't prefer, to be honest, because toxicity is a concern. And also there is a question if actually the benefit was from the quadruple therapy or from the bevacizumab. Personally, I go with actually, in the past, I go with chemotherapy. Nowadays, we have actually more options for further lines with amivantamab. But maybe my colleagues, they can actually share their experience, but I don't prefer the quadruple for toxicity.
I agree with you totally, Samah. So what do you think, Harmony study, Prof. Chris, regarding that it was, yes.
Yeah, that question had to come up, right?
It's interesting that this is really triggers such a response, right? We discussed it at the ESMO meeting, and we still wait for more data, I think, for all of us.
Yeah, we are very anxious, yes.
We are very anxious. The anti-angiogenic pathway does play a role in EGFR-mutated lung cancer, that's for sure. And we really look for something beyond ramucirumab and bevacizumab, that's for sure too. What we have to make out of this data set, we would love to see data like this. And what we have discussed today is that combination trials or combination therapeutic options is definitely the way to go for EGFR, and it's less toxic than using standard chemo or the quadruple, which obviously most benefit probably comes from the addition of bevacizumab. So, but it's interesting that we all smile if you talk about Harmony. But it's good if you talk about Harmony, you can smile.
Yeah.
Absolutely. But if I could ask the question over here to the professor and obviously the rest of the panel, a lot of these trials were obviously pre-FLAURA, pre-MARIPOSA 1, pre-MARIPOSA 2. And the other fact of the matter is that even now in 2025, 2026, we're going to see a lot of fourth and fifth generation targeted agents, plus the fact that post-MARIPOSA, post using amivantamab, lazertinib, we're going to see a whole plethora of different targeted agents that are going to come up to target newer pathways that are coming up. So what will be the value of using these anti-angiogenic agents, in combination with everything else, post everything? Because it doesn't seem to me like it's new based on the newer data, right? You know what I'm trying to say over here.
Yeah.
Yes. Okay, Chris, go ahead.
I think the great question is we have to consider what kind of population we're talking about. This is sometimes an elderly population, high rate of comorbidity. If you talk to these patients, they tell you, well, I would like to have this IO compound because this works, and this is not associated with a high level of adverse events, and that's no option for that. So if we discuss about exon 21 and co-mutations, we think about to have a workaround solution for these patients. That maybe this is the curiosity about adding an antigenic drug to an EGFR standard of care third generation TKI. I think that's basically what it is. It did work in the past, and I think people believe it's definitely better than adding chemo. That might be the whole rationale about it. In ADCs, if you work with ADCs in EGFR mutated lung cancer, PFS is shorter and they're toxic. That's one thing. And that's another question I do have for the forum here is, now we encounter in patients with common EGFR mutation these days as a resistant mechanism small cell lung cancer. And it's interesting, if you pick up a signal in the liquid biopsy, and they very often have an RB loss, And then you do, if it's accessible, you find small cell lung cancer in osimertinib. So having a TKI monotherapy obviously will lead to a certain kind of resistance mechanism we have to address. And I think this is another thing we have to consider. It's just like beyond monotherapy is probably what we have to discuss. Adding either chemo or angiogenics or ADCs. I don't really know, but that's something we can discuss right now.
Yeah, yeah.
Uh,
If you can
yes,
comment, Margaret, about this, it
absolutely.
really
Go.
depends on where do you treat your patient and your resources. If you are in area with limited diseases, you don't have this luxury of all targeted therapy, then first and second and third generation and beyond sometimes, or in the future. So if you are an area of, or a place with very limited diseases, maybe sometimes chemo is your own or the only available treatment therapy, maybe sometimes chemo plus immunotherapy. So it depends where is your patient is, where are you treating.
Absolutely.
That is definitely
Yeah, absolutely.
yeah,
This is very challenging.
yeah,
تفضلي.
very challenging in the third world and the countries with very limited resources. And also, of course, it depends on the performance status of the patient. Not all the patients can tolerate these compounds. And if you agree to go for that, or you're very brave to go for that, it's a more burden. So you need to bring the patient with each cycle. So again, you need a very good resource to catch every single toxicity profile, and you will be able and ready to treat that one. So it's a lot of things need to be considered before thinking of giving.
Perfect. I think we had a very interesting discussion. And if you allow me, we'll go for the second part. It's my pleasure to introduce our next speaker, Dr. Dalia. She's us.
Assalamu alaikum, everyone.
عليكم السلام. عليكم السلام. I'm Dr. Dalia. So, Dr. Dalia, she is Dr. Dalia Shorbagi. She is a medical oncology consultant in SMSC in United Arab Emirates, and she is assistant professor of oncology in Tanta University. Dr. Dalia, she will share with us a case presentation with Exon 20 as well. Thank you very much, Dr. Dalia, for joining and sharing your case. The floor is yours.
Thank you so much, Dr. Marvid. I thank you for the panel for the excellent and great discussion, actually very nice discussion for the lung cancer. So today I'm going to share with you one of my patients. She's a metastatic lung cancer with uncommon mutation of exon 20 abnormality. So she was 59 years old in 2019 when she first presented to the hospital with cough and loss of weight. And if you remember, in that time, it was the era of the COVID and these things. So she started to have some medication for the cough and the suspected COVID. However, her initial X-ray and CT scan, and here you can see the PET CT scan, it showed clearly a lesion in her right lung, and we've done for her EPAS examination as a baseline assessment. It didn't show any active nodal metastasis, so it was only localized lesion, as you can see here. It was around 4 centimeters. So, and they biopsied the lesion, and it showed a clear lung adenocarcinoma. TTF1 positive. So the patient case was discussed in the tumor board, and we decided to go for lobectomy, and it was like stage 2B NCLC adenocarcinoma. If you remember, on that time, it was the application of the ADAURA trial with the adjuvant Tagrisso. So I decided to go and do for her NGS and the tumor, resected tumor, and it showed EGFR exon 20 insertion mutation. So the patient received adjuvant standard of care treatment of platinum-based chemotherapy for 4 cycles, and she was kept in follow-up. Exactly 1 year after finishing the adjuvant chemotherapy in May 2021, She presented again to the ER with a behavior changes, with headache and some vomiting. And this is her MRI in 2021. Clear frontal lobe and parietal lobe lesion, single lesion with mass effect, as you can see here. And so we took the patient again, start of course on steroids and supportive measures, and we took the case to the MDT, and we decided to do excision of this lesion, and the excision showed the lesion to be of lung primary with TTF1 positive histopathology testing. So her baseline PET CT scan at that time in 2021, in May 2021, showed the mediastinal lymphadenopathy, just a small thyroid nodule. And at that time, there was a debate between whether to do a biopsy from this mediastinal lymph node again and whether to go for another NGS or not. And honestly speaking, we decided to go for another NGS just to be sure that the patient have the similar molecular alteration to decide about her first line treatment. So she did resection of the brain tumor, and she did radiotherapy after that. And the repeated foundation test showed the similar EGFR alteration of exon 20 insertion positive, and her PD-L1 status was positive and around 40%. So the question came, so we take the case and we discussed her again in the MDT discussion, and we have different treatment option came from the tumor board. One of the physicians said, okay, we'll go for osimertinib. However, another group of patient advised of our colleague advised to start with platinum-based chemotherapy. One colleague said no, platinum-based plus IO, anti-VEGF, or to start on amivantamab. So the patient, based on the available data on that time, on 2021, we started her on platinum-based chemotherapy and kept her on maintenance chemotherapy, Alimta, for a few months. And exactly 1 year after getting the disease progression into the brain and the mediastinal lymph node, she had another recurrence in the same area in the brain. So her MRI showed again disease localization and progression. And at that time, we discussed the case and with the radiation therapy team, and they decided to go for SPRT and to give her a localized form of radiation therapy. This is her MRI image in 2022, and her PET CT scan actually didn't show a lot of progression. So the decision here was what to do next for this patient, whether to switch the treatment or to keep her on observation, because the progression was only into the brain, while the other areas of disease systemically was not shown any progressive disease. So two options, whether to keep the same maintenance therapy or to switch the patient to a second-line treatment that was recommended at that time, the amivantamab, and the choice was to go for the amivantamab second-line therapy based on the disease progression to the brain. So the patient actually started it in July 2022. It was still under the compassionate support at that time because it was not yet registered in this time. So the patient actually, because we know that the treatment have infusion-related reactions, so we decided to keep the patient admitted during the first infusion day. We know that the first dose usually we divide into day 1 and day 2. So we kept the patient in day 1 admitted to observe for any infusion-related reaction, which happened actually. It was happened, and the patient developed grade 1 or grade in the form of dyspnea. She developed facial redness and chills. So we kept the patient, we hold the infusion, and we started her on steroids. We counseled the immunology physician about the case, and we kept the patient, and we resumed the infusion again, but in a very slow infusion rate. So as we all know that for the grade 1 infusion-related reaction, so most of the guidelines recommend to have interruption of the infusion rate and to start the steroids with close monitoring of the patient, and we resume it in a very slow infusion rate of 50 ml per hour. And here is a recommendation as per the trial recommendation of how to manage the infusion-related reaction associated with the amivantamab injection. As you can see here, according to the grade, and if it is grade 1 to 3, and if it is the grade 3 or higher infusion-related reaction. After a few cycles of amivantamab, so we resumed the infusion as per the schedule, and the patient developed the second most common treatment-related adverse events. In my opinion, it was a grade 3 skin-related reaction, as you can see here in the image. So we interrupted the treatment. I hold it for 1 cycle, and I started here on local and systemic corticosteroids. And I actually counseled the dermatology what to do with the patient. He saw the patient and he advised her local antifungal as well as to keep on the systemic and local antibiotic plus steroid therapy. And after a few weeks of this treatment, the patient started to improve to almost grade 1, and we resumed the amivantamab, but with a reduced dose reduction of level 1. And here is the recommendation and the guidelines advice for the skin-related reaction associated with the amivantamab injection according to the disease, according to the grade of toxicity. So in January, this is her first disease progression after resection, and then in August 2022, this is her MRI, stable disease, and in November 2022, it showed her MRI follow-up showed some activity, but we did MRIs for her, and according to the radiologist, he said that it could be post-radiotherapy necrosis, and just keep the patient on follow-up as the patient was not symptomatic. So we kept the patient on follow-up with the same therapy. We didn't change it. And as you can see here, this is her serial MRI during the 2022, and in March 2023, the patient kept on same response, didn't show any disease progression, either systematic or into the brain. However, in May 2023, exactly 1 year from the second progression, the patient MRI follow-up showed again disease progression in the same area. So it is a third recurrence in the same area. And again, we consulted the radiation therapy department, and they advised another SPRT to the brain lesion. She received one shot only of radiation therapy in this time. And we actually decided not to change the treatment because the patient was systemic assessment was okay and didn't show any disease progression peripherally. So we kept the patient on the amivantamab, and her skin toxicity was okay, except of grade 2 panonychia on her lower limb. In August 2023, this is her PET-CT scan. I think between 2022 and 2023, there was some disease progression in the mediastinal lymph node. However, the patient was not asymptomatic at this point. So according to this PET-CT scan assessment, there was a discussion between us and between the radiation therapy. So the other systemic assessment didn't show any other disease progression except of the mediastinal lymph node slightly increase in size and in activity. So we counseled the radiation therapy team, and they advised to give her palliative radiation therapy to this area. So starting with January 2019, after lobectomy and adjuvant chemotherapy, the patient had her first metastasis after almost 1 year, so started in first-line chemotherapy, and 1 year after on the first-line chemotherapy, she developed brain metastasis and lymph node metastasis as well. So started on the second-line amivantamab, and since July 2022, the patient was kept on the amivantamab until January 2024. When she has a clear disease progression into the lung as well as into the liver. So almost 5 years of treatment from 2019 till 2024. Unfortunately, the patient passed away in July 2024 after starting on another line of systemic therapy. I think this is the last slide, and thank you for your listening. Thank you so much.
Thank you so much, Doctora. Very nice case and presentation. And we'll keep the question to the end. We'll move to the second presentation by the medical oncology section at Kuwait Cancer Control Hospital. Dr. Muaz will present a case of non-small cell lung cancer. Dr. Muaz, please.
Thank you, Dr. Nafisa, for the kind presentation. Sorry, kind introduction, and thank you for the invitation. I hope you can see my slides.
Yes, clear.
Yeah, so I have two cases diagnosed with exon 20, and what I'm trying to show in these cases that this disease behaves very aggressively, and at the same time it carries unusual resistance to the traditional anti-cancer therapy. So the first case, she's a 56 years old female. She's non-smoker. She presented initially in September 2021 with 1 month history of shortness of breath and cough. She was investigated in one of the general hospital, first by CT scan and then by PET scan, which showed widespread metastatic disease. There is right upper lobe mass and multiple variable pulmonary nodules on both sides. Also, there is bilateral extensive intestinal lymphadenopathy with variable sizes of hepatic lesion, and also a widespread bone disease as well. So also with a NAV scan confirmed this bony metastasis, and a trial of transbronchial biopsy on October 2023 showed, or the sample was favoring non-small cell adenocarcinoma. However, unfortunately, the material of this biopsy was insufficient to do further molecular testing and PD-L1 test. So the patient was quite symptomatic, and and plus we don't have really a good molecular test in our hand. So because of the symptoms, we proceed with 1 cycle of chemotherapy, and then we will we'll do further testing. So we gave her 1 cycle of pemetrexed carboplatin with dose reduction because the patient has performance from 1 to 2, and we requested liquid biopsy because the tissue was really, the tissue was difficult at that time, or repeating the tissue is difficult. Plus, by MRI brain, she had also multiple brain lesions, both cerebral and cerebellar, and we admitted the patient after a few weeks from this scans because of poor oral intake and poor general condition. And the patient at that time was unfit to receive the 2nd cycle. And the liquid biopsy results, came back with positive confirmation of exon 20 insertion, and this is by Guardant 360. And After this test, we don't have window to initiate any further treatment. The patient deteriorated in the hospital, and she was unfit for any further treatment. And we involved the palliative team, and unfortunately, we lost the patient in December 2021. So just to show how this disease behave very aggressively, sometimes with the start of the symptoms. The other patient, he's a male, he's a 55 years old gentleman, he's ex-smoker. In December 2018, also he had respiratory symptoms by cough, chest pain, also he had fatigue. The CT scan in December 2018 showed left lower loop mass with multiple mediastinal lymph nodes. The MRI brain also showed widespread brain lesions. A CT-guided biopsy was positive for TTF1 and feathering non-small cell lung cancer. This is the tissue biopsy of this patient, confirmed the exon 20 insertion. So during that period, there is no standard of care, and really, there was suggestions from some of the papers in the literature to give high dose of osimertinib. So we tried this way with high dose Tagrisso plus gamma knife to the brain lesions. Unfortunately, very shortly after starting osimertinib, there is further progression in the brain, and also in the CT scan, chest, abdomen, pelvis showed further progression in the chest as well as in the bone. So clearly we can see how the mass in the left lower lobe. And we proceeded with the chemotherapy, and unfortunately after the carboalimta or carbometrixate, there is further progression in the brain, and now there is liver metastasis. The patient had received whole brain radiation, and also we went to another line of treatment, carboplatin paclitaxel. This is the MRI liver. We can see how the lesion on the left hand side is get peripheral with edema as well. There's further brain progression by the other MRI. This is the MRI you can see before and after. This is 2 months apart. The October PET scan also showed there is more progression in the hepatic and bony lesions, as well as the chest disease. The patient, unfortunately, had further failure to the systemic treatment, and after, about 1 year of treatment, we declared the patient for best supportive care, and, we lost the connection with this patient. I have another case. This is the PET scan of this patient to show you. Third case, also he's a male, he's non-smoker. In the August 2022, he presented with hemoptysis and right shoulder pain. The chest X-ray showed right upper loop mass with right perfusion. The chest CT confirmed the size of this mass is 5.2 by 5.4 with multiple right-sided pulmonary nodules and right-sided perfusion. The CT scan, there is no evidence of brain metastasis. The biopsy confirmed the malignancy, and the molecular test also showed exon 20 insertion. Patient performance status was accepted at that time. He was started on carboplatin and pemetrexed in September 2022. The CT scan, the first CT scan, showed mixed response there is slight decrease in pulmonary mass. However, there is new pulmonary nodules, and also there is more effusion and pleural metastasis. This is the CT scan. We discussed the case in the MTT, and fortunately, there was at that time we failed to bring the amivantamab in our center, and the patient shifted to another line, but unfortunately, patient had frank progression, and also we lost the connection because he went to his home country. With that, I finish my cases, and I will give the mic back to Dr. Nafisa.
Thank you. Thank you so much, Dr. Muad. And unfortunately, you were not able to give the right medication at the right time for the 3 patients. And
yes.
I think the founding the new medication will give a new hope for a good number of patients, inshallah.
Inshallah.
Without further delay, I'm going to introduce the next guest for today, Dr. Riyad Mohsen. Dr. Riyad is a consultant of adult medical oncology, Hamad Cancer Center, Qatar. And Dr. Riyad is the head of the MDT, thoracic MDT. He will discuss, I think, another cases of non-small cell lung cancer. Dr. Riyad, please.
Thank you, Dr. Nafisa and Dr. Mervat, and thank you, everybody. Greeting from Doha. And I would like to request Dr. Muad to stop sharing his please.
Inshallah.
Thank you. Actually, my case is a unique case in 2 things. She is still alive, fortunately, and no case like this case. Can you see the slides?
Not yet.
Yet. Okay. Let me share again. I think now you can.
Yes.
Yeah, we can see them very clear now. Yes, please.
Very good. So thank you very much for the invitation. And I'm going to present only 1 case, who is a 40-year-old Filipino lady. She is never a smoker. She's married with 2 children. No significant past history. She presented initially with 8 months history of progressive dry cough, no hemoptysis or weight loss, and no loss of appetite. This is her CT scan, which showed right upper lobe mass with aggressive features, with mediastinal and lower cervical lymphadenopathy, concerning for the primary malignancy, for histopathologic correlation, and it showed also bulky left adrenal gland. PET scan, it showed large hypermetabolic right upper lobe mass with central necrosis. Also, it showed enlarged hypermetabolic lymph node and mediastinum in the mediastinum and right hilar region, and highly suspicious for nodal disease. Also, hypermetabolic lymph node in the cervical region. So the case was discussed in the thoracic MDT, and the diagnosis after the CT guided biopsy was pulmonary adenocarcinoma, solid variant, ALK negative, PDL strongly positive, 100%. And the staging was clinical T3, clinical N2, and M0. So the recommendation is for EBUS, ultrasound of the neck, and we discussed with the IR about FNA core biopsy of the right supraclavicular lymph node. And if negative, to consider neoadjuvant chemotherapy followed by surgery. Ultrasound of the right supraclavicular area, it showed no enlarged lymph nodes. Now, the patient came to the clinic and I discussed the plan of management with her, and she showed understanding. EBUS was done in November 22, 2021. right paratracheal lymph node, endobronchial ultrasound guided biopsy, fine needle aspiration, showed no evidence of malignancy. The right hilar lymph node, ultrasound guided fine needle aspiration, showed malignant cells consistent with metastatic adenocarcinoma. So the patient was referred to thoracic surgery for evaluation for resection. She had mediastinoscopy done in December 2021. Lymph node 2R and 4R were taken, and lymph node 1 excision, it showed positive for metastatic carcinoma, and the other one, it was negative for metastatic carcinoma. Rediscussed in the thoracic MDT. At that time, we received the EGFR result. It was insertion, exon 20 insertion. And this is the staging. The plan was for neoadjuvant chemotherapy, followed by restaging and possible surgical treatment. This is her PET scan after 3 cycles of neoadjuvant chemotherapy. It was done in February 26, 2022, which showed partial metabolic and morphologic response in the right lung primary, metabolic resolution of the right lung hilar and thoracic inlet lymph node, with residual uptake in the right upper paratracheal station. No new lesions were found. So by March 29, 2022, she completed 5 cycles of chemotherapy, and then she underwent VATS right upper lobectomy and lymph node dissection. That was in April 10, 2022. The pathology, the same, pathological staging, YPT2BN2. And the discussion in the thoracic MDT just to do follow-up. A repeat PET scan was done on September 13, 2022. It showed this right supraclavicular lymph node, and it showed also uptake in the thyroid gland consistent with thyroiditis. For that, she was referred to the endocrinology for evaluation. And for the cervical lymph node, for ultrasound guided biopsy of the cervical lymph node, which was done in September 28, 2022. The pathology showed metastatic adenocarcinoma consistent with lung primary. Now, we discussed also in October 23, 2022, and the plan was to refer for radiotherapy because it is the only single lesion of metastasis for SBRT, and to consider systemic second line chemotherapy / targeted therapy. SBRT was completed on November 19, 2022. She received 40 grays in 5 fractions, and we requested a non-formulary amivantamab. This PET scan was done on February 22nd, 2023, which showed 2 new intense hypermetabolic lymph nodes are seen in the right upper paratracheal region and right hilar region concerning for metastasis. So this is the only lesions. Started on amivantamab on March 5, 2023. She tolerated the treatment well, and she had grade 2 skin rash managed conservatively with the consultation with the dermatology. Her rash was mostly in her scalp area, and by February 2024, she completed 26 cycles with no issues. A PET scan was done on May 22nd, 2023. As you see here, there is no evidence of disease. Another PET scan was done in January 4, 2024, and there was a lesion in the liver, small focal uptake in the liver at the left and right lobe border, corresponding to hypodense area, might represent disease involvement. Recommendation MRI, and the MRI of the liver was done, and it was highly suspicious. It's simple cyst, it is not metastasis. This is the PET scan, which was done in January 24, 2024. And this is which showed the liver lesion. And the MRI showed this is a liver cyst. She was seen in the clinic on April 24, 2024. The patient was, consistently complaining of persistent dry cough with occasional thick sputum production, no hemoptysis. So a repeat PET scan was done in May 5, 2024, and it showed thickening of the left bronchial tree and even left aspect of the trachea, showing metabolic activity and causing narrowing of the left main bronchus. Might indicate malignant process or severe immune-related inflammatory response. So biopsy was recommended with bronchoscopy. The patient, rediscussed also in the MDT and the plan to refer to pulmonary for a bronchoscopy. Bronchoscopy was done and BAL was positive for pulmonary tuberculosis. So as I mentioned, the bronchoscopy was done in May 22nd, 2024, and it showed TB smear and PCR was positive. The patient was admitted to the CDC hospital and started an anti-TB treatment with significant improvement in her symptoms. During that period, the amivantamab was kept on hold, and another PET scan done in August 14, 2024, which showed FDG avid, right lung, hilar, and paratracheal lymph node are persistently FDG avid and concerning for metastasis. But we discussed the case in the MDT, and we prefer just to do a follow-up PET scan after 3 months because of her disease could be secondary to her TB. So the latest discussion in the MDT was done in September 29 this year, and the plan is to repeat the PET scan after 3 months and rediscuss the case. Latest clinic visit was on 24th of September. She was asymptomatic and she gained 6 kgs. And with that, thank you very much for listening.
Thank you very much, Dr. Yao. That was very interesting case and extremely well managed. And congratulations, this is a good achievement for the patients. I think we do have a couple of minutes for the questions. So I'm asking kindly Dr. Dalia and Dr. Muaz to join the discussion regarding the case. The first question from Dr. Hind from Morocco. She's asking you, Dr. Dalia, about the correlation between, you pointed out that your patient had the grade 3 skin toxicity. Do you think that there is correlation between skin toxicity and the response to amivantamab? Especially your patient is almost 18 months PFS. So what do you think?
Thank you for the question, Dr. Hind. Actually, I didn't see with my colleagues, actually the other colleagues who used the amivantamab. It's one of the common treatment-related side effects, yes, rashes, but I didn't see it among other patients. And the other patient had a very good response as well. So I don't think it is a correlation. However, as we know, the EGFR is highly expressed in the skin, and this could be the relation between the toxicity and the treatment. However, I don't think it's a correlation between the response and the rash. I don't think so.
I agree with you, Dr. Adel. Do you think that because of this is also the question for the whole panel. So do you think that the toxicity profile of amivantamab is a little bit barrier for using as a medication, especially the infusion reaction and the skin toxicity? I think most of the physician, when we are looking on the data, and myself, I didn't use it yet. I asked it for one patient, but unfortunately, as Dr. Muaz pointed in his cases, those patients, they are rapidly progressive. So I didn't have so far a hand-on experience on the medication. So do you think that infusion reaction and skin toxicity is one of the barriers for this medication? Because we can think that this is not an easy medication to handle. And the other point also, we can see that the PFS for the patient on the Cresels, it was about 8 months, and on Papillon, it was 11 months. And we can see that down the road, but on the other side, the patient who didn't receive the medication, like it was presented by Dr. Ma's 3 cases, and those patients, they were lost shortly because we didn't have a proper medication for them. So again, the question is, do you think the toxicity profile of amivantamab would consider a barrier for this medication?
Thank you, Dr. Amirbat, for the question. Very important question. I used to think it the same way when I started to use the medicine, but after learning how to manage the toxicity and to be proactive from the beginning. So after starting this and after what I saw with the patient, so I started to be very careful and to educate the patient how to manage the skin toxicity early on and how to apply the steroid ointment and to report for any toxicity to me. Honestly speaking, I have another patient, but actually it is AGFR. I'm using it in the second line after failure on Tagrisso, and the patient didn't have any toxicity, honestly speaking. And don't forget that we have a formula with amivantamab and a subcutaneous injection, which doesn't have any skin-related or infusion-related reaction. So it's not that difficult if we know how to manage and to prepare the patient. So the pre-medication is very important, including the antihistamine, including the steroids, including paracetamols, including the steroid topical therapy. All these measures very important to be started before and to educate the patient about it as well as our staff. The other point you highlighted, Dr. Mervat, about I forget it. Can you remind me?
It's considered a barrier for the physician. Yeah, I think we don't have alternative. I think this is the only medication for exon 20. Yeah,
I think we are talking about unmet needs, patients who are having
absolutely.
unmet needs.
Those
Myself, I
patients,
lost one patient, you lost one patient, Dr. Mu'ad just
yeah,
now
myself
mentioned
as
three
well.
patients, and a lot that we don't know about. So I think being proactive, educate ourselves about how to deal with the toxicity, health education for the patient and for our nurses, health educator, how to deal with the toxicity, how to prevent them from the beginning. I think this is the best scenario. But being skeptical about using it when you have the right patient, I think no, it shouldn't be like that way. It shouldn't be.
And you, Dr. Riyad, your patient, she received 26 cycles of therapy. So give us your thoughts regarding the toxicity and skin manifestations, and how do you handle the situation, please?
Yes, Dr. Amirbat. If you have the right setting and the right preparation in the nurses, we need to do nurses education about the drug, because it is not given like any other chemotherapy or other medication. It has to be given in a certain schedule, have those one day, the other day, and the pre-medication. Actually, I held the amivantamab for a quite short time. And then when I reintroduced it again, she developed severe reaction. She was about to die. So it has to be given in a well-controlled situation. But as the patient tolerate the first dose, then it will be very easy for her to continue. So only the first dose which might invite problems. Other than that, the continuation is very easy.
Perfect, Dr. Riyad. And it was drawn my attention that the patient, when she developed the hepatic lesion, and I agree with you totally that the lesion by scans MRI it came as a cyst. However, we're still skeptical about this part because this cyst or the uptake on the PET scan, it wasn't before regarding the liver. So your perception was right. It may be progression. And this may give me the question that for you, Chris, as well, and Dr. Riyad, that For some patients, you may find mixed response. The patient may respond to the primary lesion, and on the same time, we may find that the patient develop another lesion like this. So if we are put in consideration, it came positive as a hepatic lesion, and we are suspicious about this part because this lesion wasn't before. If it is cyst, it can be from the start. And so we are seeing, especially with not on exon 20, we are still exploring, but we saw before in mid-exon skipping mutation, we can see monoclonal and polyclonal as well. They may responding initial to the primary lesion, but they develop mets. So how we handle this population, Chris, that you have a mixed response?
So this is very intriguing question, because I personally believe that we do have micro lesions. We don't see that on the CT scan, but I followed with high curiosity the wonderful presentation of this perioperative case. And you do see patients obviously have micro lesions in the neoadjuvant setting, and then postoperatively, they early on develop brain mets. And this is something pretty much like we do see in small cell lung cancer patients. Obviously, exon 20 patients, maybe similar to skipping 14 mutations, are prone to be a multisystemic and multilocular disease, and it's not limited. So I liked your idea of the approach to use neoadjuvant treatment options in these patients.
Perfect. And the last question, because of the time, to Dr. Maaz, and the question from Dr. Ahmed El-Gindi from Egypt. He was asking about the tolerability of 160 osimertinib, which was used. Is it tolerable for the patient, and what is the toxicity profile for this patient? We know it's not working for this patient even with high dose, but I think he was referring that the leptomeningeal disease before we were using. So I think his short question regarding the tolerability of 160.
Yeah, so as I recall, the tolerability of this dose was good. There's no, unusual like skin rash or unusual toxicity of osimertinib. For the most part, it's well tolerated. But as you said, Professor Mervet, this is really it's not effective in this disease particularly. But as I recall, for this patient, the tolerance was good. There's no signs of unusual safety profile.
I agree with you. And there is another question as well from Dr. Hadir from Saudi Arabia. She's asking about that. Do you think that the short course of the rapid course of the disease due to the exon 20 or patient performance status or the tumor burden?
So I guess
she's
both,
asking.
Yeah,
I think
so
all
guess,
of them.
both of them. The disease is aggressive, plus the presentation of high burden disease. This makes the things worse and make this more quickly progressing, and make the patient unfit for any chemotherapy or any other anti-cancer treatment. But
I guess
again,
this is I think it was interpreted by the case of Dr. Riyad that has a small lesion and the patient tolerability. I agree with you totally. Okay.
Yeah.
And because of the time, I'm sorry we do have a lot of questions, but we cannot hold. So I would like to thank our speakers and their sharing their cases with us. And it's my pleasure to introduce our next speaker, Prof. Christian Groh. Prof. Christian is a professor of medicine and medical oncology as well in Germany. He will give us the keynote lecture today for the update and the management of metastatic non-small cell with EGFR exon 20, and also he will share one of his cases as well. Prof. Groh, thank you very much for joining us and sharing your experience. Thank you.
Thank you very much for your kind invitation, and we have to say thank a lot to this great audience. You're always accumulating these people coming and listening to these great cases, and we learn a lot. And I did learn a lot. In my case now is minor compared to your cases, but maybe it's a good example how we try to interact to get the best patient therapeutic options we do have. And Dr. Merwert, you will move my slides. I think maybe that's safer if that's working. So basically what we heard today is that different from exon 19 deletions or exon 21 L858 lesions, EGFR mutated lung cancer of exon 20 is a very complex disease. And if you look at the standard slide, we always like to see there about 2%, but what we have learned today, maybe due to the high throughput and the in-depth sequencing approaches we nowadays can use, we will find probably more patients is in the EGFR exon 20. And insertion deletion tended to be the worst case scenario, poor outcome patients despite the fact that they have EGFR mutations. But a lot of things have changed over the last couple of years, and I will try to discuss that with you today based on what we have seen and what how we have come so far. Go to the next slide, please. If you look in total numbers, you can see this is a slide I just picked up just to give you an idea. In terms of numbers, now only just like for the US or for Europe or for Asia, exon 20 cases, if you try to track these down, then there are still a considerable amount of patients who still have exon 20 disease. And we all find these patients very challenging in terms of understanding that these patients obviously have a poor outcome. They are light or never smokers. They tend to be younger. And they obviously have signaling cascade disturbed by the EGFR tyrosine kinase cascade that obviously makes this a poor outcome population. So in terms of numbers, it's still a decent number, and compared to the rare mutation we have discussed today, like ROS1, it's a fairly amount of patients we probably see in our institutions if we specialize in treating patients with lung cancer. So the next one. What's really interesting, because we now have really a large wave, a plethora of new data, and if you only look at these data of the surface of the cytoplasm and of the cell surface, you see different kind of receptor tyrosine kinase targeting issues we have found. On the left side, you see RBB2, HER2 mutations and fusions. You see the neuroregulin-related fusions, and on the other side, you see exon 20 and other EGFR mutation like 18. So overall, this obviously is a major mitotic pathway to drive lung cancer homeostasis. So obviously to address this is definitely helpful. And discussing that with you is an issue of getting more and more specific in terms of addressing every insertion deletion mutation, or combine a tyrosine kinase inhibition approach like we like to do in exon 19 and exon 21, or a combination approach as we discussed today. Obviously, we need a broader approach to treat these patients. So the next slide, please. So if you do an in-depth sequencing, you see a lot of different kind of mutations. I didn't highlight that in detail for you because we don't really know if this is really necessary to find out a specific receptor tyrosine kinase inhibition pathway for all our mutations. But sequencing in depth, obviously you see in the C helix and the beta helix and others, you see definitely more things to come. So the next one. You here have current clinical trials in exon 1 insert deletion. You see on the top, you have the Papillon trial, and you have other TKIs. And I will discuss it at least in detail what these at least came to. And the oldest one we have discussed that today was mobocertinib, and that was a standard tyrosine kinase addressing only exon 20. And you see on the right side, it caused a lot of toxic side effects. And by now, we don't have this as maybe as a role model, but it's not available anymore. And we treated some of our patients with that with more or less effective treatment scenarios. So overall, you see there's a lot of going on, and this is my case now. The next case, that's it. Next slide is fine. So this is a 50-year-old female presented with cough and minor weight loss in now 6/21. And you see this is a small nodule in the right upper lobe, and it turned out to be a non-small lung cancer, an adenocarcinoma, TTF1, and the resurgence. The thoracic surgeons talked about that case with us and said, or maybe that we just like send them to PET-CT and we do all the sequencing by now for all our patients. And this was in right upper lobe. It was diagnosed like this. It was TT1 positive. The next one. Next slide, please. You see it was a poorly differentiated non-squamous non-small lung cancer. It was a small lesion, actually, 18 millimeter in diameter, but it had that complex microhistology, like being acinar, papillar, pyretiform, and it had a macular pathology finding which had two different kind of mutations. It had the exon 20 indel and had the pyrosin and PIK kinase mutation as also. And it didn't just like really, despite the fact that it has a lesion in the right upper lobe, the mediastinum didn't really light up in terms of having a very high SUV uptake. So the next one. Then this patient was operated on, no neoadjuvant at the setting, and it was at that time a PT1B, a PN2B, and it turned out to be a complex operation because they operated as an uniportal VATS. They did a VATS resection, and then they find out obviously there is definitely more tumor on a micropapillar level that they had to switch to an anterolateral thoracotomy with an end-to-end anastomosis. And at the very end, they showed up to have an R1 resection. So they didn't like that at all. And they said, well, and then we have the radiation protocol coming on for this patient. We started to do the radiation local in mediastinum, 66 gray in 21, and then an adjuvant treatment option. So this was at that time already for the tumor board an unusual case. And then the follow-ups were okay, no evidence of disease, And now finally, this patient showed up with pleural lesions. And the PET-CT scan, which we did at that time, said, well, that's not a typical enhancement, but it had a supraclavicular lymph node like the case Dr. Mohsen presented now. Obviously, this is something we don't see that often actually to have, but this is probably based on the fact that the radiation therapy was localized and centralized to the mediastinum in the local radiation. So supraclavicular lymph node are not included in that radiation field. So the next one. So then they developed soft tissue lymphangiectasia, and on top of that, and then we reinitiated treatment option, having chemotherapy, carboplatin, nab-paclitaxel, and bevacizumab. She had a persistent leukopenia. We did a bevacizumab maintenance. We just did another extirpation of the lymph node or the tumor right wall. We showed that atezo did work, and then we had the chance to get that patient into the protocol of the chrysalis after we did the thoracoscopy, drainage, and partial prolectomy. And we had a big discussion at that time because amivantamab was not available at the very beginning before that. That was the problem in 23. In 24, we said, well, we can initiate that. And we did initiate amivantamab and starting that in early 24. And it turned out to be a game changer for that patient. She is stable, she likes to travel a lot, and she's really doing good. So obviously, we did something good with amivantamab in a later line, and we hope that will continue to be the case. And comparing that to the cases you have presented, obviously, if you use amivantamab at a later line, it still has an effect. It's very interesting that this has a high affinity for control of disease burden, and it does cross blood-brain barrier, as we have seen in other patients treated after chrysalis protocol. So this is, I think, it's a pretty good case. If you know at the time that this patient has a mutation, you might end up having the right treatment option if this is available in your country, as we have talked about that before. So the next slide, please. What I would like just to discuss with you in a little bit more detail is a different kind of signaling cascade which might be of interest. And next one is we have the exon 18, 19, 20, and 21, you see that most of these deletions in exon 20 that's compared to the deletions we find in 19 or 21 are no point mutation, but they're insertion deletion mutations. And for that reason, it was difficult to address these lesions, and it was difficult to find the right pharmacological treatment option. So one of these options were poziotinib and mobocertinib, and I'll give you some detailed information about that, because at that time, obviously, that was the way to go for rare mutations. And we still see, and this is what Dr. Merwat already pointed out, and is just that at the time of development of these new drugs, that was like 10 years ago, the TKI hype was definitely large. And for that reason, we see a lot of data coming up now with TKI data in rarer mutations. And we don't really know if this finally will lead to an approval of these drugs. Like in mobocertinib, at the end of the phase 3 study failed, and it's out of the market by now. So next slide, please. But you see, this gives you in detailed analysis how complex things become. Now, if you look for refractory exon 20 mutations, you have to look for different kind of options, like patients with either an exon 20 mutation of EGFR or HER2 exon 20 insertion. You have to look for patients with prior or no prior disease or treatment naive. This is a real challenge, not only for the companies, because it's a rare disorder, but also for all of us to get these patients into clinical studies. So this is one example of things going to look like. And that's the reason how most of us will just have to follow molecular pathology tumor boards to understand what's going on in the market at the moment. So this thing's getting very, very challenging. And that's only one exon 20 of EGFR. Next one. So on the right side, see the most common deletions. Brought that picture because you see this, there are rare mutations in the rare mutation scenario, and there are more frequent mutation. But even that doesn't ultimately translate, and I will show that on the next slide, is in the waterfall plot. I hope this comes up next. Next slide, please. That we have to find out if these different kind of mutations will respond to any kind of treatment. So in this cohort of that study, it ended up being an exclaimed extension cohort, and that was a phase 3 trial for the mobocertinib. But I will show you the next slide, please. That obviously compared to that mutations, the expectation at that time was that you have different kind of classic insertion deletion mutation. They might respond to their drug and others won't. And that's exactly what the problem is in addressing exon 20 mutations with insertion deletions. Some of these mutations might respond and translate into an inhibition if you control them. Some of them won't. And that makes things a little bit more complex. And that really ultimately calls for a combination treatment or a drug which broader addresses the problem we are facing by saying that lung cancer mitosis should be stopped not only by using one selective tyrosine kinase, but by other options too. So on the left side, the standard drugs, on the right side were the newer drugs. And you see here, if you look for them in the waterfall plot, to give you that idea, you had to test all these different kinds of insertion deletions. You see the waterfall plot in this context is very fascinating that obviously there are some of them which won't respond. We do see that the same for the fusions too, for neurogaline, for ROS1, for EMA, for ARC. Some of the fusion will respond to the treatment of the tyrosine kinase and some won't. And it's not only the question of the co-expressed molecular drivers, but also about the respective insertion deletion. So I really would just like ask ourselves, we should just address a little bit broader our approach and the sequence we are using at the moment, using chemo, platinum-based chemo, and then followed by other options, or amivantamab is definitely something a way to go. The next slide. So if you go back to the slide about the current clinical trials, the game changer definitely was the presentation of Papillon last year at the ESMO. And I think this is something we have to look for. It's just like amivantamab plus chemo, where the chemo alone, obviously leads to a very impressive PFS. And following that overall idea, what we have to say is the other drugs we are seeing here, will give you show you some of these data are still at the stage where we have to think about what kind of efficacies they do have and what kind of side effects they have. And we have discussed, next slide, please, the amivantamab trial for the reason because it's a new drug. But I give you some information because this is, I think, very important to us about another drug, about the drug called trastuzumab deruxtecan, about the HER2 mutations. And the reason I'm telling you that, next slide, please, is that HER2 alterations are pretty standard fare in breast cancer. They are no standard fare for us in lung cancer. And bringing HER2, trastuzumab deruxtecan, to lung cancer, like 1.5 years ago, was something like a new kid on the block with new potential side effects, ADCs, with their pneumonitis rate, etc., etc. But we had a learning curve. I'll show you the next slide, please. We had a learning curve, and you see again, HER2 mutations are common, and it's in lung cancer, maybe 2%. And now we have a couple of patients already being treated with trastuzumab deruxtecan, and it does work. We have just this pretty much like we will have with amivantamab. We have to identify these patients, and then we can treat these patients, and we can learn from other entities who really have expertise in that. In that case, the ADC found its way very effectively to be a standard player now in lung cancer. And we just now deal with the side effects as professionally as we did before. Next slide, please. So this is good data. This was published in Lancet Oncology this summer. And obviously, this is definitely a new player, and we learned the side effects to control. And I think the overall efficacy of these newer drugs like bispecific antibodies or ADC is very helpful. So coming back to exon 20 mutations. Next slide. I just mentioned about the Papillon trial, and we have discussed that before. We have seen this slide. This is a large trial with 300 patients. I think the amivantamab addition to chemo is definitely something what we had to learn. And just we can just go rapidly through these slides because you have seen them before. The progression-free survival is very impressive, is 11.4 months, and we haven't seen things like that before. We do know by now that IO obviously doesn't play a role in exon 20 patients, and the overall efficacy of this data combination is something what we really look for. So the next slide. And the key results show that both the response rates and the PFS of the first subsequent therapy is still very stable. So overall, I think amivantamab, if available, is definitely a very important new drug for our patients with exon 20 mutations. And starting with that combination or as a follow-up, both definitely has an advantage over the standard fare we have seen so far for exon 20 patients. So I personally believe the addition of that bispecific antibody is definitely a very important issue, and addressing the issue of intravenous infusion reactions that can be probably managed by using the sub-Q option. The sub-Q option is a little bit problematic because it's a large volume you have to install sub-Q. So that might be the problem for patients who are very lean, problematic issue. But overall, this is definitely something in terms of handling what we would like to see with more drugs in lung cancer. Next slide. So that does work. What we do definitely see on the right side is that we have to learn the rate of discontinuation is fairly high in these clinical studies, and we have dose titration, and we do have patients who not only require corticosteroids on a high level, but also require prevention of thromboembolic events by using anticoagulants. So this is something we have a learning curve, but once this has been managed in the outpatient scenario working in, that definitely is something we can just like control and monitor and the patients have a high benefit, and tell you, as shown before in the case that we have seen, that these patients have a definitely symptomatic relief within a short period of time. Next one. At the very end, is there a role for other ADCs? Like we have seen data here from the Tropion Lung 05, and there are more data to come. I don't really know. We have to learn more about ADCs in the follow-up. We have seen the data with the trastuzumab deruxtecan, but datotumab after failure in the first-line EGFR-mutated lung cancer might be another option, or is something we can consider in patients who failed on amivantamab. So we have to think about that. We addressed that issue before. What happens once we have no amivantamab as first or second line option left? Next one. Maybe you can go through these a little bit faster. That does work in the 05 setting. The Dato-DXd does work in EGFR mutated lung cancer. Next one. And in a heavily pretreated situation, that might be an option we have to consider. We need more drugs to come after amivantamab. And some of the data I'll show you here are TKIs, like in the FAVOR study, in other clinical trials. There's one more drug, next slide, please, that is already in more detail presented at the ESMO, and Antonio Passaro showed that. And that might be sibalatinib, might be very interesting, and that's something we have in the phase 1 and 2 study with exon 20, and I think this might be something we have to consider in the near future. So for conclusion, the major goal, I think, is test for EGFR whenever systemic treatment is intended in lung cancer. I think that's basically what we have to do. It's just understand the potential mechanism which drives the lung cancer you are treating. And in-depth testing remains a challenge in a global setting. We discussed that too. And we didn't discuss that, but how we treat minimal residual disease in this setting. But overall, I personally believe that both testing the tissue and the molecular findings in the liquid biopsies is a standard of care in EGFR mutated lung cancer. And I think we have to learn how to control disease burden in these patients by learning more about the co-mutations we can find in the molecular liquid biopsy testing. So thanks a lot for this ever-moving field, for this listening to that update. Thank you very much.
Thank you very much, Chris. That was excellent talk and overview as well. Because of the sake of time, I'll just only allow one question from the audience. And the question is, do we need to do NGS in case of exon 20 patient progress? And what is the next step after failure of amivantamab?
This is an excellent next question for Dr. Passaro, of course. But this makes me think about the more we test, the more we find. And one thing I liked about the session today is maybe standard care treatment options is something what we still have to do in these patients. I don't think that we find, we have no specific resistance mechanism find so far in exon 20. So it might be interesting. And I think the off-target might be more interesting. As I mentioned, it's like small cell lung cancer to find out if this tissue has completely transformed.
Perfect. Thank you again, Chris. That was excellent and talk and discussion as well. And my pleasure to move to our next to the Stellite Symposium, which is sponsored by Johnson & Johnson. And my pleasure to introduce the chair of the Stellite Symposium, my colleague and my dear friend, Dr. Abdullah Al-Twigri. Dr. Abdullah Al-Twigri is known for everybody and one of the key leaders in lung cancer in Saudi Arabia. He's medical oncology consultant in King Fahd Medical City. He will chair the Stellite Symposium and also introduce our international guest speaker. Thank you very much, Dr. Abdullah. The floor is yours.
Thank you so much, Dr. Merfat, for the nice introduction, and I will take it from here. So thank you so much to Janssen for such invitation to Satellite Symposium. It's my pleasure to be with you, and I was in background, in fact, when we have a discussion over the last 2 hours about the exon 20 and the EGFR, and we really have a nice that has been shared by the panelists and the speakers, and really nice discussion. So it's my pleasure now to introduce Dr. Antonio Bezzero. Dr. Antonio Bezzero is a medical oncologist at the Division of Thoracic Tumor of European Institute of Oncology in Italy. Dr. Bezzero has wide experience in lung cancer field with number of contributions, scientific as well as in the literature. Dr. Antonio, he will walk us through the new milestone for the advancement of managing EGFR mutated non-small cell lung cancer. So, Prof, the mic is yours.
Thank you. Thank you very much for the introduction. It's a great pleasure for me to be here this evening with all of you and to discuss the evolving landscape for the first-line setting for patients with common EGFR mutant non-small cell lung cancer. This is my disclosure. I think that it is very, very important when we discuss about the first line of EGFR mutant non-small cell lung cancer to focus on, of course, on the major advance achieved in the last 15 years, but also on some limitation that today we are not ready to manage in the right way in the clinical setting. And this, of course, is focused on the high rate of patients that do not receive a second-line treatment when candidated to TKI in first-line setting that are more or less 30%. And of course, this is the first milestone, the first cornerstone, the use of third-generation inhibitors in the first-line setting with osimertinib. Osimertinib, of course, is the standard of care with a progression-free survival that is significantly lower when we compare to the other TKI, other gene, for example, ALK, ROS, and also BRAF, with 18.9 months, with a very good intracranial progression-free survival and a median over survival of 38 months. When we focus on the Kaplan-Meier curves of the FLORA trial, we can see that this is very significant, consider the background, and consider the limitation of a first-generation TKI to be penetrant of the blood-brain barrier. But as we discussed 2 slides ago, I think that the most interesting data in the FLORA trial were evaluated by the rate of patients receiving osimertinib, also the comparator TKI that did not receive a subsequent anti-cancer treatment. And this is very, very difficult. We are discussing more or less of 30% of patients, and this, in my opinion, is the most interesting thing to consider also in clinics for our patients. Of course, this is a part of the topic this evening. The evolving first-line mutant treatment landscape is very, very approaching fast. And here we have a lot of opportunities, some ongoing, some are ready to be a new standard of care. And of course, the 2 new pillars are focusing on the combination of osimertinib plus chemotherapy, discussing in the FLORA-2 trial, and also the combination of lazertinib, is another third-generation tyrosine kinase inhibitor, plus amivantamab, as discussed also in the previous presentation, a bispecific antibody able to interact with EGFR and MET pathway. Starting discussing one by one the new phase 2 trial, the FLORA-2 study, I think is a very well-designed trial, randomized patient with a common alteration to receive osimertinib, carboplatin, and pemetrexed versus osimertinib alone, with the possibility to prolong the use of osimertinib plus pemetrexed as a maintenance during the time. In this trial, we can see that the progression-free survival by investigators was the primary endpoint, and there was a sensitivity analysis for progression-free survival blind independent central review. Secondary endpoint, of course, include all the secondary efficacy endpoint over survival, progression-free survival, and of course, the safety. In this trial, patients with a stable brain metastases were allowed and patients were evaluated for the brain at the basal line with MRI or CT scan. In the progression-free survival on the left side of the slide, we can see that the benefit of the combination was very, very impressive, consistent with an hazard ratio of 0.62, and they also trend in the overall survival very interesting with an hazard ratio of 75, and this was the first combination showing a very interesting improvement compared to osimertinib, that is the standard more or less worldwide. The second, here we can see on the left the time to first subsequent therapy and also the progression-free survival too. I think it's very interesting. Of course, this is one of the key factors in the patient selection to focus on the toxicity. And of course, we can see that the addiction chemotherapy increased the rate of anemia, thrombocytopenia, neutropenia, very, very common related to the toxicity of the chemotherapy. And for this kind of toxicity, the rate of grade 3 is very, very high compared to the standard of care. And of course, we have more or less the same safety analysis when we consider skin disorder, GI disorder, more or less the same. And of course, fatigue is increasing. But of course, the most interesting and key toxicity here are related to chemotherapy. And then we have the second block of new perspective. And of course, there is the idea of the combination amivantamab-lazertinib. In the previous presentation, we learn about amivantamab in patients with exon 20 insertion mutation. And of course, amivantamab showed a very interesting wide range of broad tumor activity across the heterogeneity. The first, of course, is the ligand between EGFR and MET inhibition, that is a part of the capability of the antibody. Then we have a second mechanism of action, that the receptor degradation via amivantamab. And then we have a third very interesting mechanism of action, and that is in immunoprofiling action through the phagocytosis. All of these mechanisms, I think, are very, very interesting, also looking forward at the second line, the third line, but in particular the first line. And here we stay. So this is the study design of the Mariposa trial, recently published of New England Journal of Medicine, that evaluate amivantamab plus lazertinib versus osimertinib alone. We can see that the trial at the beginning included 3 arms. One arm was the lazertinib alone to evaluate the contribution of the components. And this study design is not the same of the FLAURA2, because in this study design, we have that the primary endpoint is a progression-free survival by blind independent central review, and all patients receive a brain MRI for the brain, for evaluation of the brain. So this is a very key factor for all the Johnson & Johnson trial. Also the Mariposa 2 included all brain MRI to evaluate this, and this is the first time in the history of trial with EGFR mutant disease that all patients required brain MRI. Also in the trial, we can see that only patients with common alteration were included. And before to discuss the difference in favor of the combination versus osimertinib, I think it's very interesting to evaluate the contribution of the components. So first of all, on the left part of the slide, we have the difference between lazertinib and osimertinib. And here we can see that there was no significant difference in favor of lazertinib, but we have a benefit of 2 months more, but the observation not significant. But very interesting is the safety profile. So more or less, lazertinib and osimertinib appear very, very similar, with the same rate of serious adverse event, more or less 30%. But I think a key factor is that lazertinib had a very significant reduced risk of cardiomyopathy and a significant lower rate of QT prolongation. That is a key safety profile, key safety events for osimertinib. And starting from this point, of course, I think that the major advance for the Mariposa trial that included more than 1,000 patients is the evaluation of amivantamab plus lazertinib versus osimertinib alone. And in this reassuming slide, we can see in the left part of the slide that the progression-free survival was statistically significant and clinically manageably improved for the combination of AMI plus LASI versus imertin alone, with an hazard ratio of 0.70, highly statistically significant. But in addition, in the secondary analysis that was presented by Enriqueta Felipe during the ASCO and then concomitantly published in the Annals of Oncology, we can see that the combination of AMI plus LASI versus imertin alone show high efficacy across all the high-risk subgroups that we can see on the right part of the slide. The combination of AMI-LASI improve the efficacy on the brain, improve the efficacy on the liver metastasis, improve the efficacy also in patient TP53 co-mutation, and also in patients with high aggressive disease with the detectable ctDNA. Of course, in the clinical setting, we are not able to use the ctDNA as a baseline for all patients, but having the ability to have a significant benefit more than osimertinib alone is a plus for the combination of AMI-LAS plus lazertinib here. And here we can see on the left part of the slide the second interim analysis that was requested by FDA that is always better. Here we have a P of 0.019 with an hazard ratio of 0.77 that was not reached at the time of the analysis for AMI-LASI, with a 37.3 for osimertinib, very, very similar to the FLORA trial. And on the right part of the slide, we can see the progression-free survival 2 that generally is a surrogate endpoint for benefit in OS that is always in favor of the combination AMI-LASI versus imertinib alone. And here the hazard ratio is 0.73. All data that confirm the benefit of this new combination with this chemo-free combination of amivantamab plus lazertinib in the first line for patients with a common disease versus osimertinib alone. And I think it's very important to focus also on the understanding of the safety profile of amivantamab plus lazertinib. When we discuss, and I think there are many rumors around amivantamab that is a long-term toxic drug. From my experience in Mariposa 2, but in particular for the data that I'm showing you now, this is complete mistake. This data we extract from the Mariposa, and we can see that the high rate of toxicity was identified in the first 4 months of treatment. And then there is a step-by-step decreasing during the time. And you can see with your eyes that after 12 months of treatment, there is a very low rate of toxicity related to the combination. Considering that with an enhanced dermatological management that now is under evaluation in the Cocoon trial, and also this is for the future with a subcutaneous injection, this will be very, very impressive. And why subcutaneous injection? Because at the present time, this is a reality. At the present time, there are already many data published. We have data from the Paloma 1 study, data from the Paloma 2, and also in particular data from the Paloma 3 that we published on JCO and we presented concomitantly during the ASCO this year. And in Paloma 3, patients with a pretreated disease, EGFR mutant, of course, receive a subcutaneous AMI-LASI versus IV. In this trial, we can see that the rate of infusion reaction was very, very low, and it was the key, of course, to prioritize the use of subcutaneous injection when this will be available in clinical setting. The other toxicity was lower, of course, but it was not big, significant overall. But of course, reducing infusion reaction, having the ability to exclude for patients for IV treatment, this is a very clear plus for quality of life improvement to consider the long-term overall survival that we are achieving step by step. But today, in the clinical setting, I think that some of the most interesting data presented this year are coming from this SKIPPER trial. The SKIPPER trial was a multi-core trial that tried to evaluate a different kind of a pre-medication for amivantamab IV, waiting for the amivantamab subcut. And in this trial, the investigator identified that a treatment with a high dose of dexamethasone prophylaxis reducing a significant way the infusion reaction with the rate of 22% versus 67% of the standard treatment in the previous trial. So this is the clear key for tomorrow application of amivantamab in clinical setting. But I think that the potency of the combination of amylases versus the osimertinib alone is reported also here when we try to discuss the resistant mechanism. And in these slides, we have data presented by Benjamin Bess during the ESMO. We can see on the purple data from osimertinib and the blue data from amylase. And we can see that using amivantamab and lazertinib is able in a significant way to receive MET amplification and secondary resistance in EGFR, but also is really interesting for discussing to you for patient candidate to receive amylase. There is a lower rate of TP53-RB1 loss that generally is associated with small cell transformation. But interesting and more interesting, I think that this slide is very, very beautiful. So for patients that receive amylase, we have only 27% that have alteration in the resistant pathways in more than 2 resistant pathways, compared to 42 in patients that receive osimertinib. This is the clear answer that using amylase is able to reduce the complexity of disease. This is a clear key to understand that this performance during the time the OSFR would be positive. And this is different from the FLAURA2 analysis that confirm the same mechanism of resistance for chemo-OSI or OSI alone. And of course, this is a part of the standard mechanism of action resistance that you know that generally we are ready to consider after osimertinib, that are very, very heterogeneous, very difficult to test. And this is why there are many opportunities in clinical trial, but the only one that receive an approval here is amivantamab plus chemotherapy after osimertinib, evaluating the Mariposa 2 trial that we presented last year. In my conclusion slide, to conclude this very interesting presentation with all of you, I think that it's important to confirm that today there is a continuous need to improve the clinical outcome for patients with a common disease. That is a very need for all of us that manage patients with lung cancer. The FLAURA2 is a clearly positive trial with an improved progression-free survival versus imatinib, and the Mariposa also showed similar results, but include an high-risk patient population subgroups. So we showed a significant benefit for amylase in all the different high-risk patient subgroups. The management of adverse event, of course, is a key. In a part, we have a high grade of chemo-related toxicity. In other parts, we have a higher toxicity related to the skin and GI, but only in the first 4 months of treatment, because generally there is a lower. And of course, the understanding of the first-line therapy could be also improved to delay the development of resistance, improve the patient outcomes. Thank you very much for your attention.
Thank you so much, Prof. Pezzero, for such nice an overview. And I think we have time for a few questions. So my first question is really, as you know, that now it looks like that osimertinib single agent is being challenged with different combination now. We have the FLAURA2 and we have also the Mariposa, and right now, in absence of overall survival benefit, which I think it's trending, and you have seen those, and probably in no time we may see also an overall survival difference. But at the time being, since we are still awaiting for the survival, probably many of us, we still use single agent and we leave the combo to those with high-risk disease like symptomatic high visceral co-mutations and L858R and also the other high-risk feature as well. But my question now, I don't think we will have the data. We have two different combinations now. We have the FLAURA2 and we have the Mariposa, and both are different clinical trials. Both have been compared to single agent osimertinib. So from efficacy-wise, I don't think we will have a chance to see those combination head-to-head. But the question is how we could make the decision if we are going to use combo, either for the high risk or in short period of time where we have a survival difference in both trials, from other clinical parameter like, let's say, the toxicity. as an example, which one is less toxic, if I can say that, or which one is probably the other clinical factor is convenience, the cost. So how you can give us your thought in regarding to other clinical parameters like toxicity, convenience, how you look at both regimen from all those clinical parameters?
So I think that is impossible to compare in the right way the two trials. So this is the first sentence, and I'm not here also with you to consider that one is the best compared to the others according to the single number and numerical data. So this is not my job. I think that to consider the global perspective, we have, of course, two big opportunities for our patient. And both of FLAURA2 and Mariposa are two big options in this moment. Consider the overall evaluation. I think that the opportunity of amylase, consider also the new opportunity that are ready to arrive, patritumab, ivoneshimab, is the really best in class first line treatment. Why? Because we have the opportunity to delay the chemotherapy and to combine chemotherapy later with other agents. We have the opportunity in the first line setting to have a very high efficacy on the brain, because the data on the FLAURA2 are based on the potential increase of efficacy of chemotherapy, but we know that we have no brain MRI to understand very, very well this increase in the activity. And then I think that translating data from the resistance, this is a clear message compared to FLAURA2 that amylase is a clear more potent, reducing the heterogeneity of the disease. So, and of course, more maybe the most important point is the discussion with our patient. So I'm sure that many patients will select the use of zimertin alone, but considering that generally 6, 7, 8 months are 1 progression-free survival, 2 progression-free survival, we cannot exclude to discuss with other patients that today there are 2 different opportunities. So in Italy, Mariposa and FLAURA2 are not reimbursed at the present time. We are waiting for the reimbursement approval. But we have many patients that ask to understand better, and there are many patients waiting to use a subcutaneous amivantamab. So I think that the big change in the future will be not between FLAURA2 and Mariposa, but to Mariposa with subcute versus osimertinib alone.
Yeah, yeah, that's clear. So it seems that I think we are moving to combination approach. We're still figuring out the approval and the follow-up as well. One of the also common scenarios that we may come across, and this has been we have it right now, where we start with the first line and we consider the subsequent line of therapy based on the first line. And now, since both are different combination, both are different, becoming now a new standard of care, the question is how the sequence should be, or what could be the subsequent therapy following Mariposa, what could be the subsequent therapy following FLAURA2, which sequence seems more convenient for the patient, or from kind of the easier combination or the easier sequence that you from that matter.
So if we consider the opportunity already in clinic today, I think that the sequence from Mariposa followed by platinum pemetrexed, in my opinion, is the best. And considering FLAURA2 followed by again platinum pemetrexed maybe is an option, but we know that the high rate of response and the need to have a very significant reduction is a critical point here. And there is also a lower rate of patients, the FLAURA2, that receive a long exposure to pemetrexed. If we follow the guideline after FLAURA2, we should consider docetaxel. This is not the right choice, but there are many opportunities to discuss today the rechallenge of platinum pemetrexed. I think that more than the FLAIR-2, the other opportunity is osimertinib followed by MARIPOSA-2. Because in the MARIPOSA-2, we have a progression-free survival benefit, but we have a very interesting overall survival benefit that is increasing presentation by presentation. And in my experience, for example, in the MARIPOSA-2, we have ongoing now patients that are receiving the combo after more than 24 months ongoing. And this is a clear message that the exposure to amivantamab should be considered. If we consider FLAIR-2, we are deleting from the opportunity of our patients amivantamab, because after FLAIR-2, we cannot use a MARIPOSA-2. But if we use osimertinib, we can discuss around MARIPOSA-2. So this is not because I'm an investigator of MARIPOSA-2, but generally when I discuss and when we have a new player, I think that we need to try the opportunity to prioritize our patient for the new drug. And of course, today the sequence opportunity are very difficult. I do not like to discuss one trial is better than the others. But today we have a PALOMA-3 that is positive, PALOMA-2 that is positive, MARIPOSA-2 that's confirmed only that the patient with EGFR mutant disease should be considered to receive AMI. And the clinic, the physician, should be considered the right selection. In this way, if we consider FLAIR-2, we are deleting MARIPOSA, or we are deleting amivantamab for the opportunity for these patients.
Yes, thank you so much, Dr. Bazero. I'm not sure if you have if there's any other questions.
Yeah, thank you very much, Dr. Abdullah, and thank you, Prof. Bazero, for joining us tonight. And I'm sorry to keep you awake late night. So I do just only, it was excellent talk. Thank you again. So my question that we, as you pointed out, we do have two big trials now. And we are considering that we don't have an issue regarding the cost or availability. And so both on in our shelf. So who is the patient profile you will pick? Because again, we do have a lot of experience with osimertinib. And also we started even to use FLAURA2 for the patient, young patient, high tumor burden. So who is the patient with MARIPOSA you will pick as a profile, putting in the fact that you put that the decrease over the resistance regarding the MET amplification and also the secondary EGFR uncommon mutations is lower, and it was in favor for the patient who is taking the combination regarding MARIPOSA. So if I will pick when I'm coming to a patient coming to my clinic, who is the profile I will pick for MARIPOSA?
It's very difficult to know. So, but of course, the evaluation of high-risk patient population is very difficult. So when we discuss of TP53, in my institution, NGS is a standard, but it's not the standard in all the institutions. But of course, when we have brain metastasis, liver metastasis, high tumor burden, this is the kind of patient that, in my opinion, should be prioritized for a combination. When we discuss a combination, I think that we need an open discussion with the physician and, of course, with patients. And we need to discuss the opportunity to receive chemotherapy and another kind of drug that is amivantamab. I think that data on TP53 and ctDNA are very impressive when we have a look on the subgroups analysis of the MARIPOSA, and also consider the impressive data of intracranial progression-free survival in the MARIPOSA-2 that show a very interesting efficacy on the brain. I think that this drug should be prioritized. Also because, as you know, as I discussed before, generally 30% of patients the first line will never receive a second line. So we need to prioritize the best first. For me, there is not the one winner, the best globally, but consider the limited heterogeneity later, the opportunity to use a combination with the chemo later. AMI plus LASI could be the best strategy. The cost, more or less, I agree, at the present time maybe would be higher for MARIPOSA than the osimertinib that are in the late time of development. But I think that exposing patients to chemotherapy compared to, for example, subcutaneous injection amivantamab. So I use the subcutaneous AMI for many patients with Paloma 3. This was a great, so patient in 5 minutes received the drug, and of course I think more than the second line, it was a big opportunity for the first line here. But I consider the discussion with the patient, the new player, to select the strategy. We cannot discuss and select alone. We need to discuss with the patient the opportunity, the chemo, the long-term exposure to the chemo, to the other drugs, and of course, in this way, that both the combination are impressive, consider the data.
In the study, you presented also the incidence of resistance, and it was the incidence about 13.9 versus 3 point something regarding osimertinib. So the patient with MET amplification, how will treat them on the lazertinib arm? Because we are treating this patient with tepotinib plus osimertinib, with the patient who is receiving osimertinib as an upfront. So for the patient was on the Mariposa arm, what you do for them with MET amplification?
So I think today we have no data of MET amplification inhibition after amivantamab. I think that this will be a new part of the future. But I think that the TKI are completely different to antibody, and as I presented this year in the ESMO for exon 20 shares with the zipalertinib, I think that there will be some opportunities. So we are starting to discuss the use of TKI for AMI, but of course here we have a new setting and we need to test in a dedicated clinical trial here. But for example, waiting for the combination of chemo plus ivoneshimab or patritumab deruxtecan in the ERTINA-Lung2, this could be a great option after amylase. Consider that we have a chemo-free period very, very long, and maintaining platinum pemetrexed for, I don't know, the third line or lower.
Yes, I agree with that. Thank you so much, Dr. Bazira. I think it's, I agree with you when it comes to discussion, because those are kind of discussion that you have with the patient. Describe the options, there's chemo. I agree with you that the sub-Q formulation will add much more convenience, and it may also play in the decision of the future options. So I think I will leave the mic to you, Dr. Merfat, if you would like to conclude and acknowledge that.
Thank you very much, Dr. Abdullah, and thank you very much again, Prof. Baziro, for joining us tonight. I would like to thank all speakers and sharing their experience and the case presentations as well. And I would like to thank our attendees from a different region. We have attendees from Egypt, Emirates, Saudi Arabia, and also Morocco. Thank you very much for sharing your questions and comments as well. I would like also to extend my thanks to Johnson, that they are our sponsoring tonight, and to organizing team Event Group. Thank you very much and have a good night. Thank you.